Hello everyone. I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this particular session, I will be discussing this very important topic, that is bronchiolitis. So first of all, let me tell you what exactly is the definition of bronchiolitis and what are the common disorders associated with the development of this bronchiolitis. So bronchiolitis, it is the disorder of the smaller airways. Right? It is the disorder of the smaller airways. And what should be the diameter of these particular smaller airways in case of bronchiolitis? It is less than 2 millimeters in diameter. Right? It is less than 2 millimeters in diameter. Now, in these patients with the bronchiolitis, what exactly happens? It is the inflammatory processes that affects the bronchioles. Right? It is the inflammatory process that affects the bronchioles, which are the small conducting airways less than 2 millimeters in diameter. Now, what are the disorders associated with the development of bronchiolitis? See, bronchiolitis can occur in individuals who had undergone the organ transplantation, right? And this particular bronchiolitis is also commonly seen in individuals with connective tissue disorders, CTD, right? Connective tissue diseases, and then hypersensitivity pneumonitis. So, these are the common disorders where you have the association of development of the bronchiolitis. Now, apart from these organ transplantation, connective tissue diseases and hypersensitivity pneumonitis, even the inhalational injuries as well as post-infectious conditions, there are drug-induced causes for the development of this bronchiolitis. So, the other etiologies include the inhalational injuries, and then post-infectious conditions. And we also have some idiopathic conditions. What exactly is the cause is not known. Now, what will be the clinical presentation and what are the types of the bronchiolitis? So basically bronchiolitis now, it's an inflammatory process affecting the smaller airways of size less than 2 millimeters in diameter. The etiologies commonly associated are organ transplantation, connective tissue diseases, hypersensitivity pneumonitis, and inhalational injuries, post-infectious conditions, and even certain drugs. Now, let me discuss what exactly are the types of the bronchiolitis. So we have a terminology called as the acute bronchiolitis, then followed by this acute bronchiolitis, we have another important clinical entity or a type, that is constrictive bronchiolitis, and the third important type, like we have what is called as proliferative bronchiolitis. So I will discuss all these types of bronchiolitis. Proliferative bronchiolitis. Then next we have COP, that is cryptogenic organizing pneumonitis. Right? Cryptogenic organizing pneumonitis. Then followed by that we have follicular bronchiolitis. Next, lastly, we have respiratory bronchiolitis. Okay, so these are the various types of the bronchiolitis, and we have also lastly pan or diffuse bronchiolitis. Right, diffuse bronchiolitis. So these are the various types of the bronchiolitis. Now, first let me discuss about the acute bronchiolitis. See, acute bronchiolitis is commonly seen secondary to infectious pathology, right? And that particular infection could be, right, your strep infections, staph infections, or most commonly viral infections. Okay, so this acute bronchiolitis, it commonly follows the viral infections. Then followed by this acute bronchiolitis, okay, if you take the clinical manifestations, in these individuals they'll have dyspnea, they can also have the presence of cough. So these two are the important clinical manifestations that you will have in patients with the bronchiolitis. One is dyspnea, right, that is gradual in onset, and as well as the cough. Now, followed by the terminology acute bronchiolitis, the next important terminology what we have is constrictive bronchiolitis. See, constrictive bronchiolitis, it is also referred to as obliterative bronchiolitis. Right, this is also called as obliterative bronchiolitis, or it is also called as bronchiolitis obliterans, right, or it is also called as bronchiolitis obliterans. So this constrictive bronchiolitis, it is the most common finding following an inhalational injury. Right, following an inhalational injury, this constrictive bronchiolitis is very common. And this constrictive bronchiolitis, it is relatively an infrequent condition, or it is a rare condition. And this constrictive bronchiolitis, it is not only secondary to your inhalational injury, it is also seen in patients with the rheumatoid arthritis. Right, it is also seen in patients with the rheumatoid arthritis. And in the beginning of the session, like I have discussed, like organ transplantation is associated with the development of your bronchiolitis, and particularly which particular organ transplantation, that is the heart-lung transplantation. So the individual undergoes a chronic rejection following a heart-lung transplantation. So, secondary to this particular chronic rejection, the individual may develop the bronchiolitis, or not only the heart-lung transplantation, even this constrictive bronchiolitis may also follow bone marrow transplantation. Right, may also follow bone marrow transplantation. So that is about your constrictive bronchiolitis. So this constrictive bronchiolitis, what exactly will be the feature? These are the etiologies, and another name of it is obliterative bronchiolitis or bronchiolitis obliterans. Then what will be the spirometry picture in patients with the constrictive bronchiolitis? See, spirometry in these patients with the constrictive bronchiolitis, it will show you the presence of airflow obstruction. Right, so you will have what is called an obstructive pattern. Right, you will have what is called as an obstructive pattern. And what do you understand by this word, the obstructive pattern, where FEV1 by FVC will be less than 70. Right, that is what is you mean by the word obstructive pattern. So patients with constrictive bronchiolitis have airflow obstruction and air trapping on the spirometry, where your FE1 by FVC will be less than 70. And if you take the chest X-ray in these individuals, right? The plain chest x-ray in these individuals, it is unremarkable. That means it appears normal. But whereas if you take a CT scan in these individuals with the constrictive bronchiolitis, what does the CT shows? It shows a heterogeneous airflow obstruction. Right, a heterogeneous airflow obstruction, or there can be presence of air trapping on the chest CT. Right, there can be presence of air trapping on the chest CT scan. And these individuals with constrictive bronchiolitis, they have a deteriorating clinical course, right? Progressive deteriorating clinical course. That is what you will observe in the constrictive bronchiolitis. Then followed by that, okay, let me just summarize this constrictive bronchiolitis. Constrictive bronchiolitis, also called as obliterative bronchiolitis or bronchiolitis obliterans, right? And most commonly seen following the inhalational injury, and it is a rare type of bronchiolitis, and it is commonly seen in patients with the rheumatoid arthritis or organ transplantation like heart lung transplantation or bone marrow transplantation. And spirometry will show you the obstructive pattern. Chest x-ray appears normal, but the CT scan, it will show you the heterogeneous airflow obstruction, and the air trapping will be seen on the chest CT. Then next we have the proliferative bronchiolitis. Proliferative bronchiolitis, it is associated with diverse pulmonary disorders, right? Now what are those diverse pulmonary disorders where you have the association of proliferative bronchiolitis? See, proliferative bronchiolitis can be seen following an aspiration. Proliferative bronchiolitis can be seen as a consequence of acute respiratory distress syndrome, can be seen following hypersensitivity pneumonitis, and this proliferative bronchiolitis can also be seen in certain connective tissue disorders and as well as the organ transplantation. Right, so these are all the various clinical conditions where you have the presence of this proliferative bronchiolitis. Now, see, proliferative bronchiolitis, how is it different from constrictive bronchiolitis? This constrictive bronchiolitis, I have said you, the chest x-ray, it appears normal. But whereas in proliferative bronchiolitis, if you take the chest x-ray, it shows abnormal chest radiograph. Right, chest x-ray, it shows abnormal chest radiograph. So this will be the difference between proliferative bronchiolitis from constrictive bronchiolitis. Then next we have cryptogenic organizing pneumonitis. So if you take this cryptogenic organizing pneumonitis, this affects men and women between the age of 50 and 70 years. Right, it affects men and women between the age of 50 and 70 years. And what will be the presentation of this cryptogenic organizing pneumonitis? The presentation will be in the form of dry cough, right? There can be presence of dyspnea and constitutional symptoms that may be present for weeks to months prior to seeking the medical attention. And these individuals, they give a history of preceding viral illnesses. Right, there will be history of preceding viral illnesses, and that is present in almost half of the cases. So that is about your cryptogenic organizing pneumonitis. Okay, next, then what will be the spirometry picture? The spirometry in patients with cryptogenic organizing pneumonitis, it will show you the restrictive pattern. Right, it will show you restrictive pattern. See, the previous one, like we have discussed about the obliterative bronchiolitis. In case of obliterative bronchiolitis, that is constrictive bronchiolitis, we have discussed obstructive pattern. But whereas in case of cryptogenic organizing pneumonitis, please remember it is a restrictive pattern, right? And there will be impaired oxygenation. Right, there will be impaired oxygenation. That is what you will observe in the spirometry. And if you take the chest X-ray frequently shows bilateral patchy ground glass infiltrates. Okay, so there will be bilateral patchy ground glass or alveolar infiltrates. Right, chest X-ray, it shows bilateral patchy ground glass or alveolar infiltrates. Although other patterns also have been described, but in cryptogenic organizing pneumonitis, mainly bilateral patchy ground glass or alveolar infiltrates are being present. Then coming to the follicular bronchiolitis. Follicular bronchiolitis, it is most commonly associated with the connective tissue disorders, especially rheumatoid arthritis. Right, especially rheumatoid arthritis. And this follicular bronchiolitis can also be seen in patients with the Sjogren syndrome. Right, so Sjogren syndrome is a clinical condition which is characterized by dry mouth and as well as dry eyes. That is what you will see in case of Sjogren syndrome. Right, so that is about follicular bronchiolitis. Then we have respiratory bronchiolitis. Respiratory bronchiolitis usually occurs without symptoms or physiological evidence of the lung impairment, right? So most of the times these patients with the respiratory bronchiolitis, they are asymptomatic. Right, they are asymptomatic and physiological evidence of lung impairment is also absent. That is what you will observe in case of respiratory bronchiolitis. And the last one what we have is diffuse pan bronchiolitis. And see, this is the type of bronchiolitis most frequently diagnosed in Japan. Right, most frequently diagnosed in Japan. And here men, they are affected twice than compared to that of women. Right, men are affected twice compared to that of women. And almost like 2/3 of individuals, they are non-smokers. Right, 2/3 of individuals, they are non-smokers. And most patients, they have history of chronic pansinusitis. Okay, so that is about your diffuse pan bronchiolitis. And what will be the clinical picture in patients with the diffuse pan bronchiolitis? The clinical features, if you see, they present with dyspnea, the same respiratory manifestations, that is in the form of dyspnea, cough, right, and sputum production. It is not dry cough here. In case of cryptogenic organizing pneumonitis, like it was dry cough there. But here, if you observe, the cough is associated with the sputum production. Right, the cough is associated with the sputum production. And if you do the chest examination, on examination, what is that you will observe? On examination, you will have the presence of crackles and bronchi. Right, crackles and bronchi. And pulmonary function test, if you see, it will reveal obstructive abnormalities. Right, it will show you the presence of the obstructive pattern. And if you see the chest x-ray shows a distinct pattern of diffuse small nodular shadows. Right, so you have diffuse small nodular shadows. Right, so that is what you will observe in the chest x-ray. So it shows diffuse small nodular shadows with hyperinflation. That is what you will observe in case of diffuse pan bronchiolitis. So let me just short recap. So diffuse pan bronchiolitis, most frequently it is diagnosed in Japan, and if you take men, they are almost like twice affected than compared to that of women, and 2/3 of them are non-smokers, and most patients, they have the history of chronic pan sinusitis in patients with the diffuse pan bronchiolitis. And the clinical features, they have dyspnea, cough with expectoration, and on examination you have the presence of crackles and bronchi. The pulmonary function test, it will show you an obstructive pattern. The chest x-ray shows a distinctive pattern of diffuse small nodular shadows with hyperinflation. Then finally, how do you treat these patients? First of all, you take constrictive bronchiolitis, which is also called obliterative bronchiolitis. So constrictive bronchiolitis, it is relatively unresponsive to steroids, and it is frequently progressive condition. Right, it is frequently progressive condition, and corticosteroids, they are not effective. Okay, so that is the reason why you need to give the immunomodulatory agents, right? You need to give the other immunosuppressants apart from your steroids, and the other immunosuppressants what we can give is the cyclophosphamide. That can be tried in these patients. Then you take in patients with the proliferative bronchiolitis. Proliferative bronchiolitis, corticosteroids are effective in 2/3 of patients. Right, the steroids are effective in 2/3 of patients, and even the improvement also will be very prompt. And the steroid what we need to start is prednisolone. And this prednisolone should be started at a dosage of 1 milligram per kg per day. Right, should be started at a dosage of 1 milligram per kg per day orally. And this has to be given for a duration of nearly around 1 to 3 months. So this is about the dosage of the prednisolone. Then initially you have to start with 1 milligram per kg per day orally. Then the dosage should be tapered slowly to 20 to 40 milligrams per day. Right, then you need to taper the drug, and this drug, it has to be tapered slowly to 20 to 40 milligram per day, depending upon the response. Right, and gradually this has to be weaned over subsequently over 3 to 6 months. And relapses are very common if the steroids are stopped prematurely. You have to give the treatment for 6 months in case of proliferative bronchiolitis. And if the treatment is stopped prematurely, the relapses are very common. Then you take the treatment in case of COP. right? Most patients with COP recover following the corticosteroid treatment, right? They are the effective drugs in case of your COP. The only one where the steroids are not responsive is mainly in case of the constrictive bronchiolitis. Then you see this diffuse pan bronchiolitis. Diffuse pan bronchiolitis is effectively treated with this particular drug, that is azathioprine. Steroids are not effective in case of diffuse pan bronchiolitis. So this is about, in short, related to your bronchiolitis. So bronchiolitis is an inflammatory pathology mainly affecting the airways, and that too which particular airways? Mainly the airways of less than 2 mm in diameter. And if you take the various types of bronchiolitis, we have acute, which is secondary to your viral infection. The next one is constrictive bronchiolitis, which is also called obliterative bronchiolitis, mainly seen in individuals who have the inhalational injury, also seen in rheumatoid arthritis, medications, and even organ transplantation. And chest X-ray will be normal, but CT scan, it will show you the heterogeneous airflow obstructive pattern, right? And even spirometry will show you the obstructive pattern. Then followed by that, we have proliferative bronchiolitis. Proliferative bronchiolitis, it is associated with diverse pulmonary disorders like aspiration, ARDS, hypersensitivity pneumonitis, connective tissue disorders, and organ transplantation, right? And compared with your constrictive bronchiolitis, the proliferative bronchiolitis is more likely to have an abnormal chest X-ray. Whereas in case of constrictive, we have seen it is a normal chest X-ray. Then followed by that, cryptogenic organizing pneumonitis. Cryptogenic organizing pneumonitis, it affects mainly men and women between the age group of 50 and 70 years. And they are present with dry cough, dyspnea, and constitutional symptoms also will be there. And there will be also a history of preceding viral illnesses. And spirometry in case of cryptogenic organizing pneumonitis will show you the restrictive pattern. Chest X-ray will show you bilateral patchy ground glass infiltrates will be there. And follicular bronchiolitis, commonly associated with the connective tissue disorders, especially rheumatoid arthritis and Sjogren's syndrome. Respiratory bronchiolitis usually occurs without symptoms or physiological evidence of the lung impairment. Then we have diffuse pan bronchiolitis. Diffuse pan bronchiolitis is most frequently diagnosed in Japan. Men are affected about twice compared to that of women. And 2/3 of them are non-smokers, and most patients, they have the history of chronic pansinusitis. And clinical features of diffuse pan bronchiolitis is dyspnea, cough with sputum production here. Chest examination will show you crackles and rhonchi. Pulmonary function test will show you an obstructive pattern. Chest X-ray in case of diffuse pan bronchiolitis will show you diffuse small nodular shadows with hyperinflation. Treatment, mainly you need to give steroids, but constrictive bronchiolitis, they don't have response to your steroids. You need to give cyclophosphamide or azathioprine should be given. Whereas proliferative bronchiolitis, they have a good response to your steroids, but thing is you need to give the treatment for nearly around 6 months. And if you stop prematurely, there is high chance of relapse. And cryptogenic organizing pneumonitis, they have a very good response to your steroids. Diffuse pan bronchiolitis, they have to be treated with the azathioprine. So with this, I will wind up this session on the topic of the bronchiolitis. Thank you very much.